I was presenting on cytopenias in MF and the importance of this field, this emerging field, because it's really been a hotbed of drug development, lots of new approaches being looked at. I tried to cover quite a bit actually because this sort of spans a number of different drugs and different approaches. So right now we are relatively limited in what we can do with cytopenias. We've got a few things like danazol and erythroid stimulating agents and IMiDs for improvement of anemia in particular and maybe somewhat platelets. But these are not particularly active agents, and so obviously there's a lot of need for new agents in this space. We also have some alternative dosing strategies for Ruxolitinib, which has been the backbone JAK inhibitor now for over a decade, and it's one that has a survival benefit. So obviously that is important, and you want to be able to dose it as much as you can and as effectively as you can without stops and starts and things like that. So there are some strategies which I covered, like start with a lower dose in anemic patients and then go up after 12 weeks if possible, and then also for moderately thrombocytopenic patients, patients with baseline platelets 50 to 100, there is data that 10 milligrams BID, which is a more effective dose of Ruxolitinib, may be safe to use. Even though that's not what the label says. The label says it's 5 BID for those patients. So I think that's really important to get the best bang for your buck in that platelet subgroup. So those are as far as what we can do with the agents available today. Although I must add that Pacritinib was recently approved 6 months ago, and this is a less myelosuppressive JAK inhibitor. So very interesting data. It's been looked at predominantly in people with platelets less than 100. It's approved at 200 milligrams twice a day. It is something that does not require dose adjustments for cytopenias, and so obviously an attractive agent for cytopenic patients. I think what is less clear is exactly which patients in whom to try Pacritinib versus those in whom you want to do like 10 milligram BID of Ruxolitinib and maybe support the anemia and thrombocytopenia in some other way. I think that part is not entirely clear. Pacritinib is clearly for people with patients with platelets, less than 50, which is its label, but it has certainly data in patients with platelets up to 100. Actually beyond as well, but its main niche, if you will, is in this cytopenic population, which are harder to treat. They've got smaller spleens, lower JAK2 allele burdens, higher propensity for both leukemic transformation and death, and just more difficult to treat because of their cytopenic presentation as opposed to a more proliferative presentation. So I think I tried to cover all those things, and then Momelotinib, you cannot give a talk now on this topic without mentioning that has had some very exciting data recently. 2 months ago at ASCO and EHA presented from their pivotal trial in the second line setting. It was called Momentum, where they went against danazol, and it was a uniformly positive trial. And this trial too, this drug too has some precedent where, like Pacritinib, it's had other phase 3 trials in the past. So the total data set is very robust. So this is a trial, this is a drug, that improves anemia by a different mechanism in addition to JAK inhibition. It's called ACVR1 or ALK2 inhibition. And so that drug should be coming, perhaps in less than a year. And how that will change the dynamics is also very, very interesting. Finally, beyond all these things which are there now or very soon, soon to come, there are many others that are being looked at. For example, I mentioned Luspatercept, Pelabresib. These drugs are in advanced phases of development. Pelabresib does a lot of different things, but Luspatercept is mainly for anemia, and Pelabresib also addresses anemia. So those are things I covered, and then finally there are several that are very early, which we really don't have much clinical data for yet.